Hello everyone and welcome to week 3 of Bio 6601, Environmental and Biological Ethics. Today we're going to be focusing on medical professionalism, dignity, and rights. This lecture will be divided into two primary parts. Our first part is going to be medical professionalism and the principle of benefit versus harm. And then our second part today is going to be on the Tuskegee syphilis experiments. So this is a historical case study that's going to reveal profound ethical dilemmas and violations of medical professionalism that we discussed in the first half. So throughout this lecture, we're going to examine some core ethical principles, including beneficence, non-maleficence, autonomy, and justice. We'll also consider how these principles intersect and sometimes conflict in real-world medical decision-making. So let's begin with the concept of medical professionalism. Medical professionalism encompasses the skills, qualities, and ethical standards essential for effective and ethical healthcare delivery. It's deeply intertwined with medical ethics, which serves as a guiding framework for professional conduct. Professionalism in medicine has evolved over time. It's been shaped by cultural, social, and technological changes. But despite these changes, certain core values have remained unchanged. For example, the duty to do no harm and to act in the best interest of patients is a foundational principle of medical ethics tracing back to the Hippocratic Oath. Professionalism requires healthcare providers to maintain competence, demonstrate integrity, and prioritize patient welfare over personal and institutional interests. However, several aspects of professionalism have evolved, particularly in relation to patient autonomy and access to healthcare. So, for example, there's been a decrease in paternalism. Traditionally, medical paternalism has involved physicians making decisions for patients without their input, believing it was in their best interests. This was often justified by the assumption that physicians, with their superior knowledge, knew what was best. Another change that's happened over time is an increase in autonomy. So there's been a significant shift towards respecting patients' autonomy, meaning recognizing that a patient has a right to make informed decisions about their own health care. Informed consent has become a cornerstone of ethical medical practice, ensuring that patients have the necessary information to make voluntary and educated choices. And also we've had improved access to healthcare. So another really important evolution is a gradual improvement in access to healthcare and resources, which are aimed at promoting equity and justice in medical treatment. So while many aspects of professionalism have changed over time, the fundamental commitments to acting in the patient's best interest has remained constant. So in healthcare ethics, decision-making is often guided by two major frameworks, utilitarianism and deontology. Understanding these approaches is essential to navigating complex ethical dilemmas. So for the utilitarian approach, utilitarianism is a consequentialist ethical theory that determines right from wrong by focusing on outcomes. According to the utilitarian framework, the most ethical choice is the one that produces the greatest good for the greatest number of people. This principle is rooted in the idea of achieving the greatest balance of benefit over harm, but this approach often emphasizes the end justifying the means, which can raise ethical concerns when individual rights are compromised for the sake of the majority's well-being. So in healthcare, utilitarianism might justify prioritizing resources to benefit the largest number of patients, even if this means certain individuals receive less attention or resources. So for the deontological approach, deontology is a rule-based ethical theory that emphasizes adherence to established moral rules or duties. Unlike utilitarianism, which focuses on outcomes, deontology considers the morality of actions themselves, irrespective of their consequences. So this approach is built on the idea that certain actions are inherently right or wrong, and it emphasizes duties and obligations, such as respecting patients' rights, maintaining confidentiality, and adhering to principles of fairness. So for instance, a deontologist would argue that a patient's right to refuse treatment must be respected, even if doing so might result in harm to that individual or others. These frameworks often come into conflict when applied in real-world scenarios. So for example, in emergency medicine, prioritizing patients based on who can be saved most efficiently is utilitarianism, but that may conflict with treating individuals based on their inherent rights and dignity, which is related to deontology. So effective medical practice requires finding a balance between these two approaches. This is where concepts such as evidence-based medicine, which we'll discuss, come into play. It attempts to merge the utilitarian pursuit of the greatest good with the deontological respect for patient autonomy and individual rights. So for a scenario addressing this, think back to our day one emergency room scenario where you all made rankings of how you would triage patients as a healthcare provider with the information that you did or did not know about them. So in your rankings, your initial rankings or your revised rankings based on using ethical frameworks, what would be examples of utilitarian approaches? If you were using a utilitarian approach, how would you rank your patients? What would be examples of a deontological approach? So if you were going to use deontology, how would you rank them, and would that change your rankings? And with your decision making, either your gut reaction or your revised ranking based on the frameworks that we learned about in week 1, where did you tend to fall with that decision making? So think back to that first week and kind of work your way through this. So this brings us to the topic of evidence-based medicine, or EBM for short. This is an approach to clinical practice that emphasizes the use of best available evidence combined with clinical expertise and patient values to make informed healthcare decisions. So in theory, EBM aims to strike a balance between the utilitarian goal of maximizing overall benefit and the deontological commitment to respecting individual patient rights and preferences. However, this balance can be challenging to maintain. So for example, when making decisions for large populations, statistical evidence may favor a utilitarian approach that benefits the majority. But on an individual level, respecting patient autonomy and ensuring justice may require different or even contradictory actions. Additionally, EBM involves acknowledging and integrating patient preference and values. So this is a clear nod to deontological principles, emphasizing the importance of individual rights and personal choice. Throughout this lecture, we're going to explore how these frameworks interact, conflict, and ultimately contribute to the ethical complexities of modern healthcare. So when we're talking about medical professionalism and ethics, these are our core values that we've addressed since the beginning of the class, and we're going to keep these front and center. So those values of autonomy, beneficence, non-maleficence, and justice. So let's break these down again. Autonomy is all about respecting the patient's rights to make their own decisions. It's their health, their body, their choice. So informed consent plays a huge role here. As healthcare providers, those providers need to make sure patients have all the relevant information to make decisions that feel right for them. Beneficence, the idea there is pretty straightforward. Do good. Providers should aim to benefit the patient, which means actively working to improve their health and well-being. It's that positive, proactive contribution to the patient's welfare. Non-maleficence is the one that's famous, the do no harm. So the idea is that we shouldn't cause harm through our actions or even through inaction, for that matter. It's a commitment to avoiding unnecessary harm whenever possible. And then our fourth principle, or our fourth core value, was justice. So justice is about fairness. It's making sure patients receive what is owed or deserved without discrimination or bias. This also touches on issues like access to healthcare and resource allocation. So these principles are ethical compasses, and what's interesting is how they can sometimes conflict or overlap in complicated scenarios, which we're going to dig into as we go along. So the focus on the first half of our lecture, where we're discussing medical professionalism, is going to be more on this beneficence versus maleficence or non-maleficence. And then as we dig into the second part of our lecture, looking specifically at the Tuskegee syphilis experiments, that's where we're going to dig a little bit deeper into beneficence and maleficence, but also those values of autonomy and justice as well. So let's take a closer look at the Hippocratic Oath. So I mentioned this previously, this is where some of these core medical professionalism values come from, but the Hippocratic Oath is one of the oldest and most influential documents in the history of medicine. It's been around for several thousand years, and the oath is traditionally attributed to Hippocrates. He was a Greek physician known as the father of medicine. He lived around 460 to 370 BC, and he's credited with advancing medicine as a profession distinct from religious or superstitious practices. So he emphasized observation, diagnosis, and ethical standards, things that we still value today. So the original Hippocratic Oath was written in Greek, and it was likely formulated between the 5th and 4th centuries BC. It outlined a set of ethical guidelines that included swearing by healing gods, like Apollo or Panacea, which showed the religious context, but it also showed a commitment to teaching medicine to future generations for free, a kind of mentorship code. It included standards of conduct for physicians, including principles like non-maleficence. So this original statement that was included, primum non nocere, that's the first of all, do no harm. So interestingly, the original oath forbade practices like surgery and assisted suicide, which is quite different from our modern standards. The wording also strictly prohibited providing deadly drugs or performing abortions, again, reflecting on the cultural and religious context of the time. So as medicine has evolved, the oath has been modified to fit contemporary values and practices. The modernized version, which many medical students recite today, focuses less on specific prohibitions, but more on broader principles like beneficence, non-maleficence, patient autonomy, and confidentiality. There was a notable addition made in 2019 by the World Health Organization emphasizing the responsibility to protect the environment. This is what I have selected in blue here for you to know. This recognizes that human health is closely tied to the health of the planet. So this is an example of how things have evolved over time. This Hippocratic Oath has gone from originally a very rigid, almost religious commitment to now a flexible, evolving framework meant to guide ethical practice. And even though it's been updated many, many times, the fundamental principles of beneficence and non-maleficence remain central. So with this first do no harm that was originally included, that's where the whole concept of non-maleficence come from. But the modern versions go way beyond that. So the modern version talks about things like applying all measures required to benefit the sick. That's beneficence. We're not just avoiding harm, we're actively trying to help and heal. balancing treatment approaches, so understanding that sometimes less is more. The oath specifically warns against overtreatment, which is a great reminder to be thoughtful and intentional about care. Also respecting patient privacy and autonomy. So patients have a right to make their own decisions, and healthcare providers have a duty to respect that. Also, there's this component now about protecting the environment. So the Hippocratic Oath is like a foundational ethical roadmap, but like any roadmap, it needs to be applied thoughtfully, especially when principles like beneficence and non-maleficence come into conflict. So let's talk about how these two principles actually play out in real life. Spoiler alert, as you've seen in the first 2 weeks, it's not always easy, it's not always straightforward, and there's not always a right or wrong answer. There's just a decision that you have to make, that you have to justify using accepted frameworks. So non-maleficence, as we discussed, is all about avoiding harm. It's mostly about omission, what you don't do. Like if you know a treatment is likely to cause more harm than good, you'd avoid it. It's pretty straightforward. Beneficence, on the other hand, is where we are actively contributing to a patient's well-being. This means taking positive steps to help or improve their condition. But here's the tricky part. In the real world, these principles often collide. Think about something like chemotherapy. You're giving a patient something that's toxic and can cause serious harm, but you're doing it because of the potential benefit. Destroying cancer cells and saving the patient's life outweighs the harm in this scenario. It's all about finding the balance between doing good and not doing harm. And like we're going to see in a case study here in a second, it's not always a clear-cut decision. So before we move on to the next slide, I want you to pause this lecture, I want you to take a few minutes and write down your personal definitions for the following terms: benefit and harm. Then think about those definitions as we continue to move through our lecture. So, what exactly do we mean when we're talking about benefit and harm, and how do we find a balance between these two? Here's a scenario. A patient's going to go through a surgery to remove a cyst. Everything seems fine, but during the procedure, one of her fallopian tubes get damaged and scarred, resulting in infertility. So the question is, has harm been done? So we can look at this from a few standpoints. From a physical standpoint, absolutely. But harm isn't just physical. It can be psychological, moral, social, or economic. So from a psychological standpoint, this is looking at trauma or distress resulting from a procedure. Moral standpoint is like if a patient feels that their autonomy or their dignity was disrespected. Social or economic is like the impact of infertility on their ability to have children, which could affect their emotional well-being or their relationships. The thing is, benefit and harm are rarely black and white. It's a balancing act, figuring out what counts as acceptable harm to achieve a meaningful benefit. And the tough part is that what's acceptable will vary from patient to patient, depending on their values, preferences, and circumstances. So let's talk about a real-world example of trying to find that balance between benefit and harm. We'll use adverse drug events as an example for this. So medications are prescribed all the time to prevent and treat illness, whether it's something simple like aspirin for a headache or complex like chemotherapy for cancer. The intention is almost always beneficence, doing good by helping patients feel better, heal, or manage their conditions. But here's the problem. Medications can also cause harm. And this harm isn't just theoretical, it's measurable and surprisingly common. So consider these statistics from the United States. 3.5 million physician office visits every year are due to adverse drug effects. Between 3 to 7% of hospital admissions, that's about 125,000 annually, are caused by adverse drug effects. Between 10 and 20% of hospitalized patients experience some form of adverse drug effect. And of those, 10 to 20% of adverse effects are severe and life-threatening. So what is going on here? Why should something meant to help be causing so much harm? Well, it's all about balance. When a medication is prescribed, the goal is to maximize benefit while minimizing harm. Even the best intentioned treatments have negative side effects. For example, let's say a patient is prescribed a powerful antibiotic to treat a life-threatening infection. The benefit is obvious, potentially saving the patient's life. But the harm could include side effects like gastrointestinal distress, allergic reactions, or even life-threatening complications. The challenge is figuring out whether the potential benefit of the medication outweighs the potential harm. And as we've discussed, different patients will define benefit and harm differently based on their own values and circumstances. What seems like an acceptable risk to one person could be completely unacceptable to another. This is why informed consent is so critical. Patients need to understand the potential benefits and harms of a treatment so that they can make decisions that align with their own preferences and values. And when we zoom out to a population level, these stats about adverse drug events force us to ask some really tough questions about how we balance beneficence and non-maleficence in healthcare. All right, so let's take a look at what we've learned, and we're going to apply it to a real-life ethical dilemma. All right, so now we're going to apply everything we've been talking about to a real-life ethical dilemma. Meet Danielle. Danielle is a 23-year-old woman. She's pregnant with her first child. She's unmarried, and her main support system after giving birth will be her parents. They aren't in great health themselves, but they can offer some financial support from their retirement savings. Danielle works as an elementary school teacher and has a medical insurance through Alabama Blue Cross Blue Shield. During her second trimester, around the 5th month of her pregnancy, Danielle is diagnosed with a rare and aggressive form of leukemia. The prognosis without treatment is grim. Her doctors estimate her survival at just 6 to 9 months. The kicker? The only effective treatment is high-dose chemotherapy, which needs to start immediately for any chance of survival. Here are the ethical complications. Because her type of leukemia is so rare, there's very little data on how chemotherapy affects pregnancy. But her oncologist warns that the chemotherapy is likely to be fatal to the fetus or result in significant developmental damage. Without treatment, Danielle will almost certainly die within the year. So what we have here is a classic ethical dilemma where the benefits or the principles of beneficence, non-maleficence, autonomy, and justice all collide. The questions this scenario raises are tough, but essential for understanding how to apply ethical principles to real-life situations. So let's break down the key issues. How do the concepts of non-maleficence and beneficence apply to this scenario? Beneficence would suggest starting chemotherapy immediately to maximize Danielle's chances of survival, but non-maleficence raises concerns about harming the fetus, potentially resulting in loss of life or severe harm. How is this benefit potentially defined in this scenario? For Danielle, benefit could mean surviving the cancer and having a chance to raise her child, but for her fetus, benefit would mean being born healthy and free from harm caused by treatment. How is harm potentially defined in this scenario? So for Danielle, harm could be defined as withholding life-saving treatment or delaying it long enough to reduce her chances of survival. But for her fetus, harm could be the physical damage or death resulting from chemotherapy. This is a classic conflict between harm and benefit. Doing good for the mother might mean doing harm to the fetus and vice versa, but the dilemma doesn't stop there. It also raises questions about autonomy and justice. So for autonomy, does Danielle have the right to decide to proceed with chemotherapy even if it almost certainly will be harmful to her fetus? And then as far as justice, what about the child's right to life? And if resources are limited, how does that impact the decision-making process? And then there's the consistency question. So this lays out the ethical context. Now we need to make a decision based on the frameworks that we've been taught, the values and principles of ethical decision making that we've been taught, and that's where things get even trickier. So to help us work through this, let's go through the 5-step process that we've discussed. Step 1, assume all the facts are known. In this case, we know Danielle's diagnosis, her prognosis, and the treatment required, also the likely harm to her fetus. So then step 2, focus on the principles of non-maleficence and beneficence. What's the right thing to do in terms of avoiding harm and providing benefit? So that brings us to step 3, duty deliberation. What are the available options and which one is preferred and why? 4, testing considerations. Here's where things get interesting. What would your approach be, and would it be the same if Danielle were a medical student, if Danielle were a sex worker, if Danielle was married and her spouse also wanted to have children, if Danielle was uninsured, or if Danielle was pregnant with twins? So the point of these questions is to test whether your ethical reasoning holds up under different circumstances. That brings us to step 5, the conclusion. If you're being ethical or consistent in your ethical approaches, or evaluating whether certain biases are affecting your judgment, once you've worked through that, then that can bring you to your final step of what is the most ethical choice. And importantly, what ethical principle is sacrificed the most in the decision that you make. These are very heavy questions, but they're very important ones, and they're exactly the kinds of questions you need to consider when dealing with complex ethical dilemmas in healthcare. So this brings us to the end of our first part of our lecture, where we've discussed medical professionalism. We've discussed those 4 core values and how they're applied in medicine by healthcare providers: autonomy, beneficence, non-maleficence, and justice. So this brings us to the second part of our lecture, moving on to the Tuskegee syphilis experiments. This part of the lecture is going to be a deep dive into one of the most infamous breaches of medical ethics in U.S. history. We'll look at what happened, why it happened, the ethical dilemmas involved, and the long-term consequences. Before we get into the details, I want to start by showing you this image. What you're seeing here is President Bill Clinton in 1997 delivering a formal apology on behalf of the U.S. government to the survivors of the Tuskegee syphilis experiment and their families. President Clinton's words were powerful. He acknowledged the government's wrongdoing, stating the United States government did something that was wrong. Deeply, profoundly, morally wrong. It was an outrage to our commitment to integrity and equality for all of our citizens. This apology came 25 years after the study was originally ended, and the study went on for 40 years. So it took 40 years before this study was revealed and terminated, and then an additional 25 years to receive a formal apology and acknowledgement of the wrongdoings. But this apology did acknowledge the harm, exploitation, and racism that was at the core of this unethical research. So we're going to discuss what happened by starting with some background. To understand the study, we need to first understand the disease that it was centered around, syphilis. So syphilis is a sexually transmitted disease caused by a specific bacteria, Treponema pallidum. It's often referred to as the great imitator because it mimics the symptoms of many other diseases, making diagnosis challenging. So the disease progresses through 3 stages. The primary stage is where sores, called kinkers, appear at the site of infection. The sores are typically painless and heal on their own, which could make them easy to overlook. The secondary stage is where a rash develops, often on the palms of the hands or the soles of the feet, and other symptoms can include fever, sore throat, swollen lymph nodes, headaches, and muscle aches. Again, symptomatic of many, many other things. At this stage, the infection is still highly contagious. Then there's the tertiary stage, which is the most severe stage and can occur years or even decades after the initial infection if it's left untreated. It involves serious damage to internal organs, including the heart, brain, nerves, liver, eyes, and bones. Symptoms can include paralysis, blindness, dementia, and ultimately death. During the Tuskegee syphilis experiments, researchers were particularly interested in observing how the disease progressed to the tertiary stage in Black men without providing them with any effective treatment. So this is going to bring us to the next slide for this specific experiment, the when, the what, the where, and the who. So let's break down essential details. This study began in 1932 and it continued until 1972, 40 years. It was officially called the Tuskegee Study of Untreated Syphilis in the Negro Male. The goal was to observe the natural progression of untreated syphilis. Participants of this study were told they were being treated for quote-unquote bad blood. This was a vague term that was commonly used in the region to describe various illnesses, including syphilis, anemia, and fatigue. However, for the participants of the study, no real treatment was actually provided, even after penicillin became the standard cure for syphilis in the 40s. This study took place in Macon County, Alabama, specifically involving the Tuskegee Institute, which is what is now known as Tuskegee University. And the study was carried out by the U.S. Public Health Service along with the Tuskegee Institute. Specifically, it involved 600 African American men, 399 of whom were infected with syphilis or had syphilis. This was our experimental group. And 201 who did not have syphilis. This was our control group. The men were often poor in this region. They were often illiterate, and many were sharecroppers who trusted the researchers to provide medical care and believed that they were being treated for the condition. Importantly, this was done by recognized public health officials that were trusted at the time by the participants of the study. The researchers actively worked to prevent the participants from accessing treatment even after, again, the treatment was widely available. So let's keep going so that we can get a better sense of how the study played out over the years. Let's talk about how the Tuskegee experiment was actually conducted. The study was set up to observe the natural progression of untreated syphilis in Black men over an extended period of time, starting with recruitment and the initial deception. So the participants were recruited from Macon County, Alabama, again, largely poor, rural, and predominantly a Black community. The men that were recruited into the study were told that they were being treated for something specific, this bad blood. Well, vaguely, bad blood was a vague term, but that's what they were told they were being treated for. They were never actually told that they had syphilis, and no consent was obtained for the actual nature of the study. Researchers offered incentives like free medical exams, meals, rides to and from the clinic, and treatment for minor ailments that may occur simultaneously, and even burial arrangements after death, which was important because sometimes proper burial was cost prohibitive for individuals. So this brings us to the lack of treatment. While the men thought that they were receiving treatment, they were actually receiving ineffective or placebo treatments. So even after penicillin was a standardized treatment for syphilis, the researchers actively prevented them from accessing it, including working with other doctors in the region to ensure that they would not be given penicillin as a treatment if they were seen by other doctors that were not a part of the study. These men were also denied entry into the military to ensure that they would not receive treatment through the military. The original plan was to observe the men with syphilis for 6 to 9 months to look at the progression of the disease. However, the researchers decided to eliminate treatment entirely to simply observe how the disease progressed until the participants died. What was supposed to be a study for progression of a disease for less than a year turned into a 40-year-long nightmare for these participants who had no idea what they were actually involved in. So researchers conducted blood tests, they did physical exams, they did spinal taps under the pretense of providing special treatments. The infamous special treatment, which was mentioned in letters to participants, was not treatment at all, as we'll discuss. Participants were often encouraged to come back regularly for checkups under the false impression that they were actually receiving care. More so, it was that they were being monitored for the progression of their disease symptoms. So the deliberate manipulation and exploitation of these men for the sake of research is why the Tuskegee syphilis experiment is considered one of the greatest violations of medical ethics in U.S. history. So now, let's talk about one of the most important figures involved in making this study happen. This was the nurse Eunice Rivers. She was a central figure in the study. She served as a liaison between the Public Health Service and the local Black community in Macon County, Alabama. She was so influential because she was trusted by the community. As a Black nurse with roots in the area, she was seen as a familiar and approachable figure. She helped recruitment into the study, often using her credibility and her rapport to persuade them to participate. She coordinated the logistics of the study, bringing participants to the clinic, administering procedures, and helping to maintain records. So what made her, Nurse Rivers' role in this so ethically complex? She likely believed that she was doing good by providing these men with free medical examinations and care for their minor ailments. But her involvement also helped to facilitate the deception. Participants were never told that they had syphilis, and they were instead told that they were being treated for bad blood. So by her acting as a trusted intermediary, she unintentionally enabled the exploitation of her own community. So interestingly, she is the inspiration for the fictional character in the film Miss Evers' Boys, which we are going to watch and do a reflection on for this lecture. The portrayal is somewhat sympathetic, but it's worth asking, how much did she know about the deception? Was she a willing participant, or was she manipulated like the men she was meant to help? She may have sincerely believed that she was helping her community, and I believe that to be the case. At the same time, though, her involvement does involve deep ethical concerns or questions about complicity, loyalty, and the misuse of trust. So it's very easy and clear to point fingers to certain individuals who are responsible for this study, but sometimes there are gray areas like Nurse Rivers. So let's talk about the why and some of the individuals that we know were directly at fault for allowing this serious breach of ethical misconduct to occur. So starting by discussing why this study occurred and what were these individuals trying to accomplish. The stated purpose of the study was to observe the natural progression of untreated syphilis in Black men, but there is a deeper layer to it, so one that involved scientific curiosity and racism. These researchers wanted to test a racist theory that syphilis affected Black individuals differently than it affected white individuals. This idea was based on the belief that Black individuals were more prone to certain diseases due to their biological or racial inferiority. The study aimed to replicate findings from the Oslo study, which tracked untreated syphilis in white males in Oslo, Norway from 1909 to 1928. The researchers were curious whether the disease progressed differently in Black individuals. So this was a comparative study. Public Health Service in the United States, those officials believed that by comparing the Tuskegee study to the Oslo study, they could uncover racial differences in disease progression. And this idea, again, this was rooted in racist pseudoscience and justified in the name of scientific discovery. So let's be very clear about that. The study was allowed to continue for longer than originally intended because the researchers were more interested in seeing the disease progress to its final stages than in providing treatment when we knew that there was an effective cure. Several key figures were involved in planning, executing, and overseeing this study. So Dr. Clark was the head of the United States Public Health Service at the time that the study was initiated. Originally, he framed and designed it as a short-term project meant to last 6 to 9 months, but the funding was pulled for the treatment stage. So once the funding was pulled for the treatment stage, that was when it was decided by several individuals to continue with this study long-term, knowing that there was no treatment that was going to be executed in this. So Dr. Perrin Jr., he was the health commissioner of New York State and the former head of the Public Health Service Venereal Disease Division. He was involved at this stage of deciding to allow it to continue. And Dr. Oliver Wenger, he was the Regional Public Health Service Venereal Disease Clinic Director in Hot Springs, Arkansas. So he played a significant role in designing and promoting the study and how exactly this would be conducted. So how this has progressed to this point is the study was designed, it was supposed to be short term, but then it was decided that it would continue even though the treatment component was removed. And then as it moved across additional layers, there was the design and the ideas about how this study would actually be executed. And that brings us to Dr. Bondler, who was the on-site director of the actual research program. So he was very instrumental in deciding to extend the study indefinitely and deny those participants effective treatment when penicillin came available, because he was the on-the-ground person, if you will. And because he was the on-site director, him and the other local individuals involved with this were also responsible for working with other local doctors to deny care to these individuals as well. And then we had the individuals such as Dr. Moughton and Dibble, who were the president of the Tuskegee Institute and the head of the Institute's hospital, respectively. So these individuals were somewhat supportive of this study, but it is questionable about how much they actually knew about what was occurring. But all of these men, along with Nurse Rivers, they were responsible for the day-to-day operation of the study and its continued deception of the participants. So it's important to know, as we mentioned with Nurse Rivers, not all of them had the same level of involvement or responsibility or even knowledge of what was occurring potentially, but their actions or their lack of actions contributed to the ethical violations that had occurred. So now let's break down how the Tuskegee syphilis experiment unfolded over time. 1932 is when the study began. The initial plan was just to observe the natural progression of syphilis for 6 to 9 months before providing treatment. And then in 1936, 4 years later, a major paper on the study was published, receiving criticism for the lack of clarity about whether the men were being treated. So the decision was made still to continue the study until the men died. So 4 years later, after it was initially supposed to be short term, as word starts to come out about this in the medical and the scientific community, there was a little bit of pushback, if you will. But in 1940 was when participants were denied entry into the military to prevent them from receiving standard treatment for syphilis. So again, this was a concerted effort to deny these men treatment so that they could continue observing the long-term effects of untreated syphilis. In 1945, a little over 10 years after the study started, penicillin became the accepted and effective treatment for syphilis. However, these participants were denied access to this treatment. Again, they did not even know that they had syphilis. In 1947, rapid treatment centers were established across the country for the treatment of syphilis, but the men in those studies were declined treatment, similarly to how they were declined treatment for syphilis with penicillin. They didn't know to be evaluated or treated at rapid treatment centers because they didn't know that that was what was wrong with them. In 1972, that is when the study is finally exposed to the public by a whistleblower, and it was terminated shortly after. So 40 years from the beginning of the experiment until when the experiment was terminated, and then 25 years after the termination of the experiment is when President Bill Clinton formally apologized to the survivors and their families. So this timeline shows that the study wasn't just unethical in its design, it continued to violate ethical standards even as medical knowledge advanced. So let's discuss some of these core ethical dilemmas. The study clearly did not act in the benefit of others. Instead of helping sick patients, healthcare providers made matters worse by not treating them. Individuals who participated in the study had done so only because they were influenced by outside sources. They were motivated by the advantages that came along with being study participants, but an additional influence was that they were misled and deceived about the true nature of the study and what was being done to them. The reasons for conducting the experiments were unjust, and they were rooted in inaccurate, false, and racist foundations. So these are just some of there's a lot ethically that was wrong with this, but this kind of is a high-level overview of some of these major issues that we'll dig into a little. So let's start by discussing that this experiment clearly did not act in the best interest of others. So failure to act for the benefit of the patient is lack of beneficence. Instead of providing effective treatments when it became available, researchers deliberately withheld penicillin from the patients. Even when rapid treatment centers were established in the 40s, participants were intentionally excluded. The researchers' actions violated the fundamental principle of beneficence, actively working to improve the health and well-being of patients. Also, there was deception and coercion. These men were deceived in order to gain their trust to be active participants in the study. There was no intention of treating them, and these subjects did trust, at the time, the United States Public Health Service. They trusted these researchers and their doctors that told them that they were going to give them treatment. Not only were they misled, but they were given incentives like free exams, meals, or even burial arrangements to get them to participate. So it's almost like they were motivated without giving the true nature of what they would undergo throughout this. It is particularly manipulative when you consider the extreme poverty and the lack of healthcare access that was present in that area. So here I've included that study that came out in 1936, the untreated syphilis in the male Negro, that did receive some pushback and some questions about the true nature of the study and the knowledge of the participants. And then here we have the Tuskegee study of untreated syphilis, this 30th year of observation. So as this was ongoing, information continued to be put out about it. People were aware of this, and there were individuals that clearly benefited from this. The researchers that were involved in the study, they were publishing, but the benefit did not come to the patients. That these researchers and these medical providers were responsible for not doing harm unto. So this brings us to another ethical violation. This experiment was harmful, not helpful. So actively causing harm to these individuals was a violation of non-maleficence. Not only did these researchers fail to provide treatment, they decided to withhold care actively. That caused harm to these individuals. Allowing syphilis to progress untreated led to severe physical suffering for these individuals. It also led to psychological distress, and it led to death. So when we think about harm and those levels that harm can occur at, there was clearly physical harm, there was psychological harm, there was social and economic harm. These individuals' livelihoods and abilities to provide for their family were affected. Their offspring, oftentimes, some of these children had congenital syphilis that they were born with. So it wasn't just the men participating in this study. Syphilis is an STD. Their wives and their children were affected as well. In some cases, but not all, this was passed on to these children. So when we think about, in addition to the death and the suffering of the wives and the husbands that were involved in the study or caught syphilis because of their husbands, so not only were the men that were involved in this study physically harmed, when they passed this disease to their spouses and their children, this created intergenerational harm as well. So not just that physical passing of syphilis as well, but all of that additional harm, whether it's psychological or economic, that created intergenerational harm as well. This was perpetuated far beyond the men that were involved in this study. So we'll also revisit on this false advertising that the patients had. So we discussed there was deception and coercion. They were not told about the nature of the study. They were misled. They were told they were treated for bad blood, and they were incentivized through these perks, if you will, that came along with being participants that were exceptionally manipulative due to the socioeconomic status of individuals in this area. But importantly, there was a lack of informed consent. This is a violation of autonomy. The men involved in this study were never given an honest explanation of the study's purpose and what they were undergoing. Informed consent is a foundational element of ethical research. This was completely absent in this study. Even when they agreed to procedures like spinal taps, they were told that it was part of their treatment, not a data gathering technique. So here is text from a letter that participants received. Some time ago, you were given a thorough examination, and since that time, we hope that you have gotten a great deal for bad blood. You will now be given your last chance to get a second examination. This examination is a very special examination, and after it is finished, you will be given a special treatment if it is believed you are in condition to stand it. Emphasized, remember, this is your last chance for special treatment. Be sure to meet the nurse. So the special treatment was spinal taps to continue to collect more data to look at the progression of syphilis and neurosyphilis. So as was mentioned, one of these side effects of long-term syphilis is neurological symptoms like dementia, and there are a whole categorization of these syphilis symptoms in long-term syphilis that is known as neurosyphilis. So additionally here, this is a certificate for participants in the syphilis study. This certificate is awarded to individual's name In grateful recognition of 25 years of active participation in the Tuskegee Medical Research Study, signed by the Surgeon General, issued by the U.S. Public Health Service. So this was in 1958. The Public Health Service leaders employed many strategies to keep the subjects happy with their involvement in the study so that as many as possible could be brought to autopsy. The men were also misled about this. The special certificate was distributed to all surviving participants in 1958. No, surviving participants, because some people did not survive up until this point, and praises them for their involvement in the Tuskegee Medical Research Study. Again, they did not know that this was involving syphilis. Even at this late date, 25 years later, the men did not know what they were being observed for. I won't say treated for, because they were not treated at this point. So this brings us to more details, or just reiterating why these practices were so unjust. There were racist motivations for this experiment. This is a violation of justice. The study was built on the racist assumptions that syphilis affected black individuals differently than white individuals. So let's be very clear. These experiments were rooted in and continued to perpetuate systemic racism and racist ideologies. The researchers aimed to compare the findings of their study with the earlier Oslo study that involved white men, because there was some underlying belief that there was a difference in disease pathologies in black individuals versus white individuals. Specifically, that black individuals were more susceptible to certain diseases, which is this pseudoscience underlying belief that there's biological differences. This is a clear violation of the principle of justice. There's also failure to provide ethical oversight. So for 40 years, this study continued without any meaningful oversight or accountability. And we're not talking about just like one person that oversaw this the whole time. As we mentioned with the who was involved or how did this happen, there were multiple people involved with this and multiple layers. And there were turnover of people. So at no time did anybody over 40 years see what was going on, know what was going on, and say, hey, this is not right. We should not be continuing this. There were no rules or regulations that governed how human subjects should be treated at the time, which did allow for the perpetuation of this study. The lack of oversight really enabled the researchers to manipulate and exploit participants without consequence in this case. So this went on again for 40 years until 1972. The remaining survivors were treated, and their family members, because remember, wives and children had syphilis as well. And this was only done after the news of the experiments was leaked by a whistleblower. Peter Buxton, who was working for the Public Health Service at the time, he revealed the true nature of this study to the New York Times, where it was released. And the study was terminated within a year of that leak. So let's talk about some of the immediate and long-term consequences of the Tuskegee syphilis experiment for the participants and their families. We'll start with them. Remember, this study began in 1932 and it continued until 1972. 40 years. The original plan was just to study the effects of untreated syphilis for a brief period, but the researchers chose to continue to study this indefinitely. The immediate outcomes were that by the time the study was concluded and exposed in 1972, of the original 600 men that we started with, only 74 were still alive. 40 wives of those participants had contracted syphilis. Many of them were unaware of their husband's condition. 19 children were born with congenital syphilis. This is a condition that could have been entirely prevented if their fathers had been properly treated. Congenital syphilis can cause severe deformities, developmental delays, seizures, and death. In many cases, the participants suffered and died from the disease's progression, especially as it entered the tertiary stage, where it causes neurological damage, heart complications, blindness, and other severe health issues. These men, who trusted the researchers and medical providers to provide them with the medical care that they were told that they were receiving, they were instead exploited for the sake of so-called scientific knowledge. The suffering extended far beyond them to their families and to future generations. As for long-term outcomes, the devastation did not end when the study was stopped. The effects continued to impact the participants' descendants and the community as a whole. So, medical costs and lack of treatment. Many survivors were left with long-term health complications that required extensive medical care. Financially, they were often unable to afford proper treatment even after the study ended. And the U.S. government eventually provided medical care, but it was too late for many families. There was a class action lawsuit and settlement. So following the study's termination, the NAACP filed a class action lawsuit against the U.S. government. The case, Pollard versus the United States, resulted in a $9 million settlement in 1974. $9 to $10 million. Medical care was promised to the surviving participants and their families under the Tuskegee Health Benefit Program, or THBP. The last surviving participant died in 2004, and the last widow receiving benefits died in 2009. But again, there was a long-term outcome of this that was underlying generational trauma and distrust. So the experiment left a deep psychological scar on the Black community. Many African Americans grew mistrust for medical institutions and for the government, feelings that persist to this day, as we'll see. This mistrust has impacted public health efforts, particularly when it comes to vaccination, clinical trials, and other health initiatives. So the final tally, when the study ended in 1972, out of 674 participants were still alive. The majority of the original 399 men who had died at the time died because of syphilis or related complications. 40 wives were infected and 19 children were born with congenital syphilis. But what makes these outcomes so tragic is that most of them were entirely preventable. By the time penicillin became the standard treatment for syphilis in the 1940s, the participants could have been cured. Instead, researchers actively prevented them from receiving treatment, even going so far as to deny them entry into the military where they would have been treated. These outcomes aren't just numbers. They're people, families, and communities who were betrayed by a system that claimed to be helping them. So now let's talk about how this tragedy influenced the creation of ethical guidelines that we use today, and some of the long-term costs to the society and these communities that were specifically impacted. So one of those long-term consequences is an inherent mistrust in the medical system. These experiments became a symbol of betrayal and exploitation. It contributed to deep and persistent mistrust of medical institutions among African Americans, which continues to affect healthcare access and outcomes today. Surveys conducted decades later found that nearly half of Black men surveyed believed that AIDS was a man-made disease made by the government, and over half believed that the cure was being withheld from the poor. This mistrust isn't irrational. It's rooted in real historical abuses, with Tuskegee being one of the most prominent examples. But in addition to this inherent mistrust and negative impact on society, specifically these communities that were impacted and continue to be impacted by this severe lack of ethical conduct, there were institutional changes that came about from this that have long since been needed. So we had the 1974 National Research Act, which established the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. This led to the creation of institutional review boards, or IRBs, which must approve all research involving human subjects. So even I, as a professor at Troy, if I wanted to do a survey of participants of an environmental science education and outreach event that I'm doing at a local festival, I have to get institutional review board approval to collect any data from a human. Even if it's a qualitative survey, that has to get approved by somebody else to make sure that I am not undergoing an ethical violation in my study design or harming the individuals who are participating in that study. We also had the Belmont Report, which was established in 1979, outlining 3 core ethical principles: respect for persons, protecting their autonomy and obtaining informed consent; beneficence, which is maximizing benefits and minimizing harm; justice, ensuring fair and equitable treatment of all participants. So these core values that we've been talking about, all of those kind of wrapped into official guidelines to use for medical studies or efforts involving humans. And there was a formal apology. So President Clinton in 1997, formal apology, way too late, mind you, but that apology was issued to survivors and their families. But the acknowledgement of wrongdoing was essential, because it has resulted in, as that formally came out from the government, then we continued to establish things like the National Bioethics Advisory Commission. Now we have the President's Council on Bioethics. So when the government acknowledges something, generally things are put in place so that those things do not occur again. So the apology allowed systems to be put in place, but to be clear, it could never undo the harm that was caused. So the Tuskegee syphilis experiment is a very powerful reminder of what happens when ethical principles are ignored. It has profoundly shaped the field of medical ethics, influencing guidelines, policies, and public perceptions to this day. So why does this matter today? Why are we talking about this, and why did I use this as an example to talk about in our medical professionalism lecture? Why do we continue to study this experiment and talk about its effects nearly a century after it began? Here's why it remains relevant. This mistrust in the medical system. If any of you are going on to be healthcare providers, this experiment has left a lasting legacy of mistrust, particularly among African Americans. It led to the establishments of the research ethics that we recognize and abide by today. So the backlash from these experiments led to significant changes in how we conduct medical research and research overall. There are ongoing efforts to restore trust, and that restoration of that trust requires acknowledgement, transparency, and continued efforts to improve health equity. And there are a lot of lessons that we've learned to conduct ethical research today. Research involving human subjects is heavily regulated to prevent abuses like those seen. We have the creation of IRBs, we have emphasis on informed consent and the promotion of ethical research standards. That all stems from this tragedy. Despite these improvements, ethical issues will continue to arise, so studying cases like this helps us to remain vigilant and committed to doing better. Ultimately, the Tuskegee syphilis experiments serve as a very powerful lesson in the importance of ethical standards, in accountability, and respect for human dignity and rights. It's also a reminder that ethical research requires constant vigilance to ensure we're protecting the rights and well-being of all participants. Let's conclude by breaking down the 6 critical underlying ethical issues that were associated with the Tuskegee syphilis experiments. These issues cover constitutional rights, deception, coercion, racism, lack of informed consent, and lack of oversight. So let's start with violation of constitutional rights. These participants' basic rights were disregarded. They were misled, deceived, and manipulated into participating in a study that was harmful to them. No efforts were made to protect their well-being or ensure justice. Particularly, their rights to autonomy and informed consent were systematically violated as an inherent part of this study. For the second point, the government had knowledge of syphilis and the behavior. So the U.S. Public Health Service was fully aware of the devastating effects of untreated syphilis. Yet, they made a conscious decision to withhold treatment even after the treatment became widely available and accepted as a standard cure for syphilis. Worse, these participants were actively prevented from receiving treatment. The third issue is the deception of the participants. Again, they were told they were being treated for bad blood, not for syphilis. Researchers used false advertising and misleading letters to keep the patients engaged. They were led to believe that the painful procedures like spinal taps that they were undergoing were treatments rather than efforts to gather data. The use of deceptive language to maintain their participation was a very clear violation of honesty and transparency. And this is just not deception that occurred to get them to sign on to the study to begin with. This was deception that was continuous and ongoing for the 40 years of this study. For our fourth point, the U.S. Public Health Service failed to get informed consent, tied back into what we just discussed. The participants never gave informed consent because they did not know what was happening. They were not made aware of their true diagnosis or the true nature of the study, or that there even really was a study. This lack of transparency and communication made it impossible for them to make an informed decision about their involvement. This violation of autonomy is one of the most glaring ethical failures of this study. For fifth ethical issue, this was rooted in racially motivated and discriminatory practices. So this study as a whole was rooted in racist assumptions that syphilis affected Black individuals differently than white individuals. So researchers sought to replicate the findings of the Oslo study involving white men, assuming the Black men in this study had biology that was somehow fundamentally different. The experiment exploited marginalized populations that had little access to healthcare and was especially vulnerable to manipulation. These racist ideologies allowed the study to continue unchecked for decades. So mind you, not only did they decide to conduct this study on Black men, one of the individuals from Public Health Service specifically came out and said when they were going to conduct this and decide where to conduct it, he said Macon County, Alabama would be a great place to do this study. So not only did they seek out Black men to identify if the proliferation of untreated syphilis was similar to white men, they specifically chose the individuals from this area because they were part of more vulnerable, marginalized communities. And that brings us to our sixth issue, which is a lack of ethical oversight. So for 40 years, this experiment continued with no ethical guidelines or regulations. They were not put in place when this experiment was designed, and at no point were they put in place while the experiment was going on. There was no IRB at the time or institutional review board. This came as a result of these violations of ethical conduct. There was no equivalent body to the IRB until that was created, so nobody evaluated the morality or the safety of this study. The absence of oversight allowed the researchers to exploit their subjects without accountability. So each of these ethical violations, each of these unethical issues that arose from the study represent a direct violation of these principles and these core values we've been talking about: beneficence, non-maleficence, autonomy, and justice. And unfortunately, the impact of these violations didn't just end when the study was terminated, but there are long-term outcomes from this that allow us to move forward with research having ethical standards, guidelines, and oversight now. So this brings us to the end of our week 3 lecture on medical professionalism, rights, and dignity. So we'll leave off by discussing the assignments for the week and what to look for. So we'll have a discussion for this week. Again, initial posts are due by Wednesday, and your 2 replies, minimum of 2 replies, are due by Sunday. We'll also start our movies and reflections this week. So this will be ongoing weekly throughout the semester, or the term. But starting with this week, we're going to watch Miss Evers' Boys. So this is based off of Nurse Rivers as the fictional character in the movie. So you can access this via Troy Library Films on Demand. And then after watching this movie, you're gonna undergo a reflection. So this is not a critique, like did you like the movie, did you not like the movie? This is a reflection on the ethical principles that arose from the movie. We're gonna, over the next couple weeks, watch examples of death and dying, like patients' right to autonomy and making decisions for themselves, informed consent, things of that nature. And then we have our plagiarism assignment. So you completed your initial write-ups of your summaries for those articles, and now we'll undergo the peer review component of that. So you'll be assigned 2 peers to conduct peer reviews for, and each of you will get 2 peer reviews. So you'll do those peer reviews per the assignment guidelines. By this upcoming Sunday, you'll have a week to do that. And then you'll have an additional 3 days. If you are evaluated as having a lower score on your initial write-up from myself and your peer reviewers, you have the opportunity to revise that and resubmit it. You have 3 days from receiving your peer reviews back. So those are the assignments and the additional activities to look for this week. You can find all of this in the week 3 module, as well as the week 3 overview, resource breakdown page. If you need anything in the meantime, don't hesitate to reach out to me on Canvas if you have any questions or concerns, or you need clarification for anything, and I will respond within 24 to 48 hours. Thank you all, and we'll see you next week.